So hello, everyone. Thank you for having us. I'm going to be presenting, I'm going to start the presentation on behalf of Dr. Petru and myself, Regina Oladokun. Petru is from San Francisco, and I am from Ibadan. We're going to present the why, when, and how to of HIV disclosure perspectives from the North and South. And we have nothing to disclose. Anne and I, we just met recently because of this presentation, and we rubbed minds together. And in our wisdom, you will learn she has treated children with HIV, children and adolescents, for the last 30 years. So it made sense to rub minds together, and we have accumulated between the two of us 50 years of treating children and adolescents with HIV. So a lot of what you're going to hear today will reflect on what we have seen over the years in the two services, from San Francisco and Ibadan in Nigeria. So we all know that HIV is a potentially life-threatening, stigmatized and transmissible illness, and that is why a lot of people fear it. That's why it's highly stigmatized. It's actually the most stigmatized disease in the whole world. Unfortunately, the burden among children, adolescents, and young people remain, especially in sub-Saharan Africa. The access modalities of treatment have changed over time, and the good news now is that we have the treat-all strategy, where all children and adolescents that are diagnosed with HIV, or even adults, will start treatment right away. Disclosure of HIV status to children or adults is a challenge. It's a huge problem because of the issues that we're going to talk about. The impact of disclosure and non-disclosure, so you have mixed results. You have benefits, and then you have some negative effects. When, how to disclose to children and adolescents will be crucial for optimal antiretroviral therapy outcomes. So HIV disclosure to children and adolescents, we have to note, is a gradual process. From Anne's archives, she was able to dig out this, where Douglas Shenson of the New York Times said, AIDS is a disease, no more, no less. It is not symbolic of anything. There are no victims because there is no crime. There are no innocents because there are no guilty. There's no blame because there has been no intention to cause harm. There are only sick men, women, and children, all of whom need our help. Very aptly put. So when we rub minds together, we realized, of course, that our pediatric HIV program services are similar. We have comprehensive HIV medical care with case management, mental health services, and support. We have transition education and planning. We transit differently. We transit in Ibadan and Nigeria at 15 years, while in Anne's service in San Francisco, she transits much later at 18 years, or even keeps some of the children a little longer, up to 21 years. We also offer HIV and sexual health education, supportive services, and then we have post-exposure preventive prophylaxis care as well, when children have been assaulted or have had needle stick injuries. So for Anne's program, an overview of what her program looks like. She has mainly adolescents now in her program. Just a little below 1/3 are less than 13 years. So majority are adolescents, those that are currently in the program. And the caregivers are mainly adopting parents, as you will see later. Overall, she's had over 1,000 children enrolled in her program, and most of them, a lot of them are Black. They're also Hispanics and some white. So she has a wide diversity in terms of race and ethnicity. And when it comes to the areas where the international adoption has come from, you have from South America, from Asia, and from Africa. She has 98% of her children being retained in care. 100% of them are on antiretroviral therapy. And 96% have achieved full viral suppression. Very good outcome in the program. When it comes to the Ibadan program from 2006 to date, we have something similar in terms of the distribution of the ages. Now we have very little number of children that are less than 10 years because PMTCT is also working. So most of the children are adolescents, but we transit at 15 years. We've enrolled over 1,200, and right now we have 344 in care and service. They have 38 right now in care. We've had also more mortality than in ANS service, but for the two programs, most of the mortality occurred at the beginning when the antiretroviral therapy was suboptimal. But since protease inhibitors have come into the program and dolutegravir, we've recorded much less mortality in both services. I just like to point out that in our service in Ibadan, 100% of the children are on antiretroviral therapy because of the treat-all strategy that has been adopted. And happily, we have 77% that have achieved full viral suppression when you compare to our Nigerian national average, which is 42%. We also would like to share with you the different preferred pediatric HIV ART regimen. In the US, much more complex. They have many more newer classes, antiretroviral drugs. In Nigeria, we adapt from the WHO protocol. So the new guy on the block, dolutegravir, has reached us. We're happy about it. We also have protease inhibitors for children less than 6 years. Now, some of the big and small differences that we also noted when we compared our two programs from the north and south. When it comes to the catchment population, I'd already said, for us now in Nigeria, the program has been decentralized so that within every 100 kilometers, you have a service that is offering HIV care. In Oakland, they have localized to, the program has the catchment. Children are usually coming from the large cities with, I told you, ethnic and racial diversity, and mainly adoptive parents and biologic parents. When it comes to social support, in Nigeria, we have mainly family support with some extended family because of a lot of stigma. While in San Francisco, it's broad, you have a lot of extensive family support, and they also know about the HIV status of their family members. Across all the classes in Nigeria, HIV affects all the classes. Sadly, a third of our children are orphans, such that the primary caregivers, those who are the ones now taking care of them, about a third of them are grandparents who are aged. And this, of course, is what will tell you about the kind of care and support that these children may be getting. While in the US, you have mixed, as I had said, then you have adoptive homes and so on. For health literacy, it's rather on the poor side for Nigeria when you have lots and lots of grandparents who have very little education, but it's excellent in the US. The community education and acceptance, I keep emphasizing the issue of stigma for us in Nigeria, but in the US, they appear to be very knowledgeable about HIV, and they accept it better. For the government and community support, we have very little of it in Nigeria. The government welfare support is poor. Previously, there used to be user fees, but recently the fees have been abolished for the children. Happily, antiretroviral drugs are free. In the US, on the other hand, the government supports, government funds support the program, but the antiretroviral therapy is not free. They have insurance instead, which we do not have on a large scale. The federal government and partners oversee the program in Nigeria, and the partner in Ibadan is the APIN-PEFA partner that supports us and has over the years. For the US, the non-governmental support is very minimal, such that they are independent. The service is independent, and carries out a lot of their protocols independent of the influence of these partners. So HIV disclosure in children and adolescents, we have to ponder on some questions. We know there are challenges, barriers, there are negative and positive consequences of disclosure. So should parents disclose HIV status to their children and adolescents? Should adolescents disclose their HIV status to parents, family members, and other significant others? So the why, when, how will be important. Let's start by talking about the rates of HIV disclosure to children and adolescents from some studies that we're able to come across. Going from Africa, many parts of Africa, from Nigeria to Ghana, Tanzania, we've had disclosure rates much less than 50%. We had as low as 13% in Nigeria from UCH, one of the earliest studies, and then later rose to upwards of 40%. But the US appears to be faring better. Even the earlier studies in the early 2000s, they had up to 40% disclosure rate. And right now, Anne was able to do a cross-section of her children and found that 72% had been disclosed to. So those studies that I had shared with you earlier were all cross-sectional. So we have this cohort study from Zimbabwe that looked at it from a different way. So they selected 123 caregivers and their children who had not been disclosed to and followed them up for 12 months to determine the disclosure process. And they found, the long and short of a lot of the beautiful graphs that you see here, about a quarter of the children had been fully disclosed to. But what was worrying was that the majority of the children did not know a lot of the facts. They didn't have all the details about HIV and how it can be spread and that they could even infect others. So they had concluded and recommended that we need to go further than just mentioning that children have HIV. We have to empower them with a lot of knowledge. So the significant others that we're talking about that the children could be disclosed to, could be that families can disclose to extended family members. We found this study. The majority of the people have disclosed to other family members and then siblings, older siblings of these children. And then in places like Nigeria, where spiritual leaders are, people confide in spiritual leaders a lot. They also were confided in. And then teachers, you see only 3 cases confided in teachers, disclosed teachers, because of the problem with the stigma and discrimination that I had talked about. So why not? A lot of these issues that we've talked about, stigma is there screaming at us, stigma, and then discrimination that comes from it. Stigma is the negative attitude, behavior, as I've said, and discrimination is when it's acted out, when people are prevented from accessing care for the fact that they have HIV. So this other study also gave reasons why caregivers did not disclose to their children. So some thought children were too young to understand, and others feared that if they disclosed to the children, they would disclose to their friends and others, and it would go outside the family circle and cause issues for the immediate family. And then psychological disturbance in the children, for the children themselves. They feel the children will not be able to handle hearing that they have HIV. They may start blaming the parents, or they may even refuse to take their drugs. I practiced in South Africa at some point, some years back, and I can tell you the same was happening. Some of the children, when they got to know, it actually backfired. They became depressed, they refused to take their medications, and they were acting out all the negative consequences that we have mentioned. Having said all that, in spite of all the abandonment that can happen, the fear of disclosure and all that, there are enabling factors. When we have good family function and the cultural context is right, the intellectual capacity of both parents and children is optimal, and then we have good support system for the parents, good social support system or legislative to back up and protect people from discrimination, then maybe things will be better. So I'm going to end now and hand over to Anne, and Anne will take it from there. Everything is not bad news. There are positive consequences as well when children are disclosed to. So over to you, Anne. Thank you very much.
Hello, I add my greetings to those of Gina. We had a delightful experience working on this together, and I get the privilege of talking about why disclose, because the benefits outweigh the risks. There are a lot of positive outcomes that are associated with disclosure. In the adult world, there's literature that suggests that disclosure is associated with much better linkage to care and improved antiretroviral adherence. Needless to say, if you don't tell an adult that they have HIV, it would be very difficult for them to access and maintain treatment. In addition, non-disclosure is associated with virologic failure in studies that are done over a long period of time. In the pediatric world, there's really good data that suggests there are a lot of benefits to disclosure to children. There's a promotion of trust, the sense that if the parent can trust the child realizes that the parent will be telling the truth. There will be an improved adherence, better access to support services, better communication within the family, and better long-term health and emotional well-being for the child. On top of that, children experience an improved quality of life when they feel included and understand more what they're doing. Does disclosure result in improved retention in care, adherence, and virologic outcome? I think I just suggested that that's the case, and there are a number of studies that support this. In one study looking at adherence, HIV status disclosure significantly improved adherence among children living with HIV and AIDS. In another study, retention in care was carefully documented. And I think the most dramatic is the documentation about virologic suppression. If children have been told their diagnosis, 79% of them manage to achieve virologic suppression, compared to only 40.6% if the children do not know their diagnosis. So what is that process? How do we go about disclosing? When should the disclosure take place? What factors affect disclosure? What's the best way to support caregivers to disclose the status effectively to children and adolescents? Should it be the caregiver alone? Should it be the providers alone? Or should it be together? And what is the process of carrying out disclosure in children and adolescents? So we're going to go through a bit of information about disclosure process, but there's way more to discuss than we have time in half an hour. I'm going to give you some references, and at the end, we've attached about 30 more slides that will help you walk through this process. The World Health Organization has put out guidelines on HIV disclosure counseling for children. I think it's up to 12 years of age. I can't see on my slide. The Elizabeth Glaser Pediatric AIDS Foundation has an incredible toolkit that was put out in 2018. And in that, you can get step-by-step support in the disclosure process. There also are visual aids that we've developed in my program over the last 35 years that we had borrowed from the internet in various ways. But for this presentation, we solicited help from a teenage daughter of one of our nurses who redrew many of the drawings so that they are copyright-free. And we've included them in the appendices to this slide set. Some are visual aids and some are written guidelines that might be helpful to walk through the disclosure process. When should one disclose? The general recommendation is to start as early as a child starts asking questions. If the child is asking questions and the parents are evasive, then the child will start being suspicious and won't trust what's being said to them. So even as early as 3 or 4 years old, some information can be provided. They don't have to be told the name of the virus. They may be told that there's a germ in their body and that they need medicine to control the germ. Otherwise, they could get sick. We need to assess the readiness of a child to hear the disclosure information. What is their cognitive ability? Where are they developmentally? And what's their clinical status? In my experience in the beginning, when we had no treatment and very aggressive disease, we found that we needed to help the kids understand what was happening to them. And so we would disclose earlier if a child is sicker and needed to understand the need for many treatments or interventions. And social circumstances always need to be considered. The age range or cutoffs at which disclosure is recommended vary depending on the source. As you see here in the table, in Zambia, the recommendation is for partial disclosure at 5 to 7 years old. The World Health Organization kind of recommends sometime before age 12 they should hear something. And full disclosure, which means understanding what it is, how it's treated, where it came from, how it's transmitted, should happen in virtually all children by the age of 12. And I would add that if they have the intellectual capacity to handle that information. We have some children who are so developmentally delayed that it makes no sense to tell them something when they can't process the information. So how does one disclose? There are a number of practical steps that need to be included. You need to identify the children in your clinics or children and adolescents in your clinics to whom disclosure is imminent. You need to look at various guidelines and see what would work for you. And for that, we offer these many slides that are part of the appendix. You may need to decide to do it as a committee or group of people, bring the right people together to help with the disclosure process. Because my clinic is so small, I'm involved in the disclosure to every child when they come to clinic. Sometimes we will prep the parents for what disclosure might look like, and some of the parents will take that information and do it on their own and bring the child back the next time to get more details and understanding, while many other families prefer that it happen in person when we are together. There's also some checklists. Elizabeth Glaser Toolkit has one to determine whether a child is ready for disclosure. I hinted at who should do it. Who discloses depends on what the family needs and wants. Sometimes it's the primary caregiver, the biological or adoptive mother, father, or healthcare worker with them, or maybe the healthcare worker doing most of the disclosure. What about a newly diagnosed adolescent? These teens need to hear this information. They need to get it fairly quickly. They need to be given enough information that they can understand, and they need to be plugged into care as quickly as possible. The sooner you make that disclosure, the faster you can get them into clinics, and the faster they'll get onto treatment and well controlled. We know that those newly diagnosed adolescents are often loaded with huge amounts of virus and are highly risky to other populations if they transmit. So the sooner we make a diagnosis, the sooner we will get to zero. Zero new diagnoses, zero transmission. After disclosure, you need to think about a lot of things. You have to document in your records that the child has been told the diagnosis, but you cannot presume that they really get it. You need to monitor and evaluate the effects of the disclosure. Some kids will get very depressed, withdrawn. Others will want to go scream it to the world. You need to remember to repeat and reinforce information every time you see the children in clinic. You need to support them and their families. Look at what their peer relations are, whether they've told other people. One of the things that I found was very interesting is that almost all kids want to know immediately, you've just told me a big, big private bit of information. Who else knows? Who in the family knows? The children need to know who's safe, with whom they might be able to discuss the new diagnosis. And look into whether they are able to continue with their other interests, activities. Are they participating in school? What's their mood like? Are there behavior changes? We need to look at all those things which can be consequences of disclosure. And for adolescents, you definitely would like to give them a sense of community. And if you can, set up an adolescent clinic day or youth clinic day in your clinic, it would be a nice way to offer them peer support. There are a number of peer-led strategies in Africa called Operation 000. In the US, we call it Getting to Zero. We want zero new transmissions. We want to get there as quickly as possible. I'm going to walk you fairly quickly through the appendices just so that you can see what's there. And these slides are going to be made available to you as part of this conference. So first we have some tidbits for child and adolescent healthcare providers, and I'll just walk you through those very quickly. The main focus here is that it's a process, not a moment in time. You have to consider the age-dependent pre-diagnosis steps and the developmental considerations. You need to look at family issues. Are they with biological parents? How are they coping with their own diagnoses? And how will they be supportive to their children? What about adoptive parents? Our experience is that the adoptive parents find it easier to disclose because they don't feel the burden of guilt or shame as compared to biological parents. But they also have the same fears about how children might handle that information. We also need to help them understand whether it's that it's private information, but that there's certain things they can talk about within the family. There's also, when there are many children, a tendency for one child to be treated specially. They are the special child, the sick child, and there's a tendency to spoil them, or conversely, to neglect them. And we need to be really careful about how this is handled in the family. Social and societal issues. What triggers parents to choose to disclose? And we've heard some of those already, but these are all summarized in this appendix. And we also need to understand in each community what the words AIDS and HIV mean for people. Have they already had so many people in their family or in their community die of AIDS? And do they think of AIDS as meaning death? Or does HIV have a connotation related to a particular family member for whom they either had very warm or very cool relations? And what about adopted children who come from dire circumstances, or these orphans that Gina described? Have they already had traumatic experiences, and are we going to add to that, or how are we going to help them cope when we give them a diagnosis? So how do you start telling the story? This set of questions walks you through that. How I tend to do it when I talk to children. I tell them how much they are wanted or loved within their family, but that there was a problem that was discovered and that the parents are ready for them to understand. Do they know what they have? What does it mean for them? And are they ready to hear more? We talk about the name. We talk about the medicines. And what about these adolescents? It's not too different than with younger children, but you need a more sophisticated level of discussion. And you cannot presume that they understand anything accurate. They hear things at school, they hear things in the community. It may not be true. And so we need to provide accurate information and repeat it often. As I said, repeat it often. I'm going to give you two examples of children where developmental stages had a significant impact on what they got when we told them. I have one 16-year-old boy I follow now, and we told him about 3 or 4 years ago that he had HIV. And in clinic last week, he said to me, when we had this discussion for the 50th time, "You mean I have HIV?" So what was he hearing the first 3 years? Was he processing it? Did he just not have enough understanding? And another teen whose parents told us they did not want us to tell him his diagnosis was sick enough and required IV therapy, and the therapy was being given at home. And a nurse came to the house, and while she was drawing his blood, she spilled some of it, and he warned her, "Be careful, I have HIV." Whereupon the nurse called me and said, "Guess what? This patient knows what he has." And so he's been living with this knowledge and has been unable to talk to anyone about it for the prior 3 or 4 years. We have to be really aware of how important it is for kids to understand. There are resources available, not always readily available in all parts of the world, but we were able to find some. And there are some sweet books that are written for kids, normalizing that one child may have HIV and the other may not, but the kids can play together, they can do things safely together because they need to understand how it is and how it is not transmitted. The second set of appendices here are our visual aids. And some of these, as I said, are ones that were drawn by the nurse's daughter who works in our clinic. We spell out what the names mean. We explain about germs, different ones, different sizes, different examples. We explain about the immune system being a shell around the outside of the children, and that these germs and diseases are the invaders, and we want to try to keep them safe. This is one of Indy's clever drawings. On the left, children with no medicine, where they have very few green T cells and lots of nasty HIV, the purple monster. And on the right, they become stronger. They have medicines on board, many more T cells and far less virus. So we try to help them understand it in this context. These are many other slides that were borrowed from mostly the CDC, but very useful, especially for older children, helping them to understand the differences between HIV and AIDS, how you can get it, and how you can't. How you get it, differences when parents are infected, that there are different times when it can be transmitted, and that the risk of transmission to a baby when a mother is on treatment is 1% or less, and with no treatment, it was 25% in the early 1990s. So in conclusion, since HIV respects no age, no gender or race, the North and South, Nigeria and the United States, uniting in the global village, we've asked and discussed the why, when, and how to disclose. This is a task that should be accomplished in all clinics around the world for optimal outcomes for all children and adolescents living with HIV. And I share with you a very courageous patient, the one on the right, who at age 14 wanted to wear this t-shirt to school. And the school principal said, I don't think that you should do that because I can't guarantee that you'll be safe. But he wanted to know that nobody knows that he's HIV positive. On the left, a reminder that nutrition is important, and we talk to kids about that all the time. We want to thank the teams that work with us in Oakland. Teresa and Catherine are two nurses working with me for the last 20 years. Chantel is our social worker. And in Ibadan, the team that is working with Regina and her colleagues, we appreciate the help and support that we get from all of these people. Thank you. We have references and more and more. And I've included some video resources that we find very helpful that hopefully you'll be able to access as well. In particular, the last one was recently added to YouTube. It's a channel that was started by one of my former patients. I took care of her from the time she was 2.5 years old. She's now 25 and studying astrophysics at the University of Heidelberg in Germany. And she decided, after all these years, to come out to the world with the fact that she has HIV. It's very courageous. It's been very successful. But I do remind you that you should watch it first before you encourage teenagers to start looking at it, because it's pretty blunt. Thank you very much.